Our speaker today is Dr. Richard Ford, who is a professor emeritus in medicine at the North Carolina State University College of Veterinary Medicine. Professor Ford is a graduate of The Ohio State University. He practiced small animal as well as equine medicine prior to completing the internal medicine residency program at Michigan State University. He then taught internal medicine at Purdue University from 1978 to 1982, and subsequently at North Carolina State University from 1982 to the present. Throughout his career, Dr. Ford has published 5 textbooks and over 300 papers on topics relating to infectious diseases and immunization. Currently, he is the lead editor of the American Animal Hospital Association Canine Vaccine Guidelines and a co-author on the American Association of Feline Practitioners Feline Vaccination Guidelines. Please join me in welcoming Professor Richard Ford, who is going to give us a fascinating presentation on vaccine titer testing. Dr. Ford?
Well, thank you, Dr. Ahn. I appreciate that. I'd like to add my welcome to the webinar. I wanted those of you who are not familiar with the holiday scheme in the United States to know that we have just completed one of our major holidays, Thanksgiving, which is a time when families and friends gather around the table and eat and watch American football for 3 consecutive days. Now, one thing I have learned from this year's Thanksgiving in interacting with family, friends, and children is that when a 3-year-old child hands you anything like food, a toy, or even a hug, it's really the flu. And in my case, it's kennel cough. So I'm struggling a little bit. Please forgive me if I hack, gag, and cough a bit during the presentation. I'll do my best. This webinar is specifically developed to address antibody testing or serology in clinical practice, particularly for 3 antigens: canine distemper, canine parvovirus, and canine adenovirus. I wanted to emphasize before we begin that the whole concept of antibody testing at the patient-centered level is relatively new in veterinary medicine. And so as we proceed with this from the patient management perspective, I wanted to emphasize that antibody testing provides really a very important, and I think right now, underutilized resource to the table in practice. It's important enough that the AAHA canine vaccination guidelines have actually incorporated the antibody testing technology into the guidelines, which I'll discuss as we proceed. Let me explain a little bit where this started. I want to take you back a few years when the vaccination guidelines recommended intervals for boosters be changed from every year to every 3 years. Now, this was quite a dramatic divergence. At the time, veterinarians resisted change significantly. And I think over the years, most practices today, certainly all of the veterinary schools in the US and Canada, teach a 3-year booster interval for the adult dog regarding the core vaccines for the dog and cat. It was veterinarians who questioned whether or not this was a valid recommendation that prompted the decision to do antibody testing. In other words, I really don't trust you guys who write the guidelines, so I want to know for myself, does the patient still have antibody 3 years after I last vaccinated? And that's largely history at this point, as most practices, although not all, have moved to a 3-year or even longer interval. But what's interesting to me is the sustaining factor. And rather than the veterinary profession now driving antibody testing, it appears largely to be the public is driving, the client. I think that from my experience, public concerns about over-vaccination, and in particular, the purported relationship between measles vaccine and autism in children has driven clients to actually question the need for vaccination and over-vaccination. It is interesting, as a sidebar, I've had 2 requests from pet-related magazine editors this year to interview me about an article on how vaccines given to dogs cause autism. It's a total extrapolation, completely invalid. It was a very short interview, to say the least. But I wanted to tell you that there is this element that is driving some of the market today for antibody testing. I think many of you have perhaps experienced that. Historically, let me just briefly go back and indicate or address where this antibody testing business has been in play in veterinary medicine. And really, the roots of antibody testing clinically go back to herd health. Here's an example of a flock of birds in which in the US and many other countries, these are hundreds of thousands to millions of birds at risk. And in the process of managing herd health, these flock managers will actually go into individual pens, kill 3, 4, 5 birds, and test for antibody to several different antigens. There are test kits available for that. They do this on a weekly basis. And there's always a little bit of background antibody present, but as they do this, every once in a while, they might discover a pen of birds that has an extreme number of positive tests for a specific antigen, which indicates that there is an impending threat to the flock. And what they will do on that in order to manage the health of the herd, or the flock in this case, is literally eliminate that entire pen for the sake of the balance. So that's been antibody testing for actually many years in veterinary medicine, but that's changing. Today, companion animal medicine is actually asking for what's the antibody titer in that cat. So technology has evolved to the point where it is capable actually to do this kind of testing on individual animals. So with the access to patient-centered antibody testing or serology, what has happened is we find in talking to many veterinarians that there are some very pivotal questions that need to be addressed. And that's what this webinar is about. It's a short webinar, but I wanted to highlight the fact that one of the pivotal questions that I get is, are these tests really valid? If the patient is positive, is it in fact protected? Valid question. That is also driving, why would I even test? If it is valid, what are the indications for actually doing an antibody test in practice? And there's a third question, and that is, how do you interpret the test results? And this is a critical issue, and a fundamental point behind this webinar is to assure that you understand that a test result is one thing, but it entails the clinician's interpretation. What do I do? What's actionable if the test result is positive or negative for a specific indication? So we'll start with that. I wanted to highlight to you that antibody testing or serology for vaccine-preventable diseases is the focus of the discussion, and I think you know you can commercially access antibody tests for a myriad of pathogens, bacterial as well as viral and even fungal. But in relation to what we're talking about regarding vaccine-preventable diseases, distemper, parvovirus, adenovirus, panleukopenia, I wanted to put a little bit of didactics on the table here and mention to you there are two fundamental platforms for doing antibody tests. I think this is relevant to the discussion. First is quantitative testing. That's laboratory-based reference standard testing. There's also a qualitative testing platform or semi-quantitative testing platform, which avails itself to use in practice. And that's really a focus of what we're talking about today. The quantitative testing is the titer. It is a dilution. It gives you a number. It is an endpoint test. You will not do antibody, quote, titers in practice, unless you have a very sophisticated laboratory and trained technologists. The laboratory reports come back to you with a titer result and a comment, which is generally positive or negative. Now, please understand this. When the laboratory reports a result as positive, all they are saying is that the sample had sufficient antibody levels to meet or exceed a defined threshold for that laboratory. It is not an assessment of the patient's condition. That is the clinician's responsibility to make that interpretation, not the laboratory. When you submit samples to a laboratory, the results do require 2, 3, and perhaps longer days to get the results back. The advantage of the qualitative or semi-quantitative testing platforms is you get a yes or no answer, which correlates well with the positive or negative result you would find in the quantitative testing platform. It is amenable to in-clinic use. It's rapid, generally from 8 to 21, 25 minutes. So it moves along quickly, and it is possible to do these with the client still in the practice. One point I really wanted to emphasize to you, and this is a take-home message. There is exceptional correlation between a positive test result and protective immunity for canine distemper, canine parvovirus, canine adenovirus, and feline parvo or panleukopenia virus. This is a very well-established concept done during the challenge studies for licensing of vaccines. The correlates are well known, and if you do have an access to the notes, I've cited several independent papers that confer this kind of information. So the point I want to leave you with is that for these 4 antigens, a positive titer is an excellent correlate of protection. Positive test, positive titer means the same thing. With regard to in-clinic point-of-care testing in the United States, there are 2 kits available. Outside of the United States, only the Vaccinate is currently available, as I understand it. The Vaccinate test kit is the most recent technology for testing antibody, and there are test kits for distemper parvoadenovirus. That's one test kit. A separate test kit will also provide antibody to feline panleukopenia. For veterinarians in the United States, Zoetis also sells a test kit that they had purchased from a company several years ago called TiterCheck. These results are only for canine distemper and parvovirus versus the 3 antigens provided on a test for Vaccinate. Now, I wanted to mention to you that the test on the right, the TiterCheck test by Zoetis, and the Vaccinate test shown on your left have both been validated or correlated with the reference standard titer tests. And there is, and I repeat this, there is exceptional correlation between those. A positive is a positive, whether it's a titer or a color change on a card. So be aware of that. I would also mention to you that the test kit on the right, the TiterCheck test kit by Zoetis, is more suited for batch testing. It is more labor intensive, although it requires both tests can be conducted within 25 minutes. The advantage of the Vaccinate is you can either do multiple patients at once or an individual patient. A nice opportunity there. Now, when it comes to doing the tests, I wanted to at least put on the table for you that these are valid, well-studied tests that correlate very well with antibody titers done in a reference lab. But one point that I think is very critical is the interpretation of the test results. And I wanted to briefly highlight this. This is kind of an awareness issue for you. When we're talking about a positive test result, I would like you to think PI. The acronym PI in this case represents the interpretation of the test results when the test results are positive. Some antigens that are for which the test result would be positive indicate the patient is protected. Others only indicate the patient is infected, while other positive test results are interpreted as the patient has been exposed. This is a very fundamental but important concept for any clinician interpreting serology test results for infectious disease. Now, if you look at just protected, and we've already established this, I wanted to reiterate that for distemper, canine and feline parvovirus, and for adenovirus, a positive test result, whether quantitative or qualitative, is a correlate of protective immunity. All right, now to challenge the audience, and this is where doing a webinar is a little more challenging. I would like to interact with you on this. When I ask you, when a test is positive, which tests does it correlate with infection? Not protection, not exposure, but infection. Think about that. Which positive tests give you an indication the patient is infected? All right, the most common one that we're probably familiar with is leptospirosis. Leptospirosis antibody is a very poor correlate of protection. It is used diagnostically for infection. Also, it is not a good correlate of prior exposure because antibody simply doesn't reside very long, literally weeks or months at the most. Lyme disease antibody, if you are using the IDEX C6 antibody or antigen platform for C6 antibody, is a correlate of infection. Now, it is antibody testing, but that platform, unlike the others that are out there, the multiplex test kits that look for antibody to outer surface protein C, these are not correlates of infection. Those could be a result of vaccination. The C6 antibody for Lyme disease on the IDEXX SNAP or the quantitative test does correlate with infection. And likewise, FIV, feline immunodeficiency virus antibody, is a correlate of active infection and is used diagnostically. None of those correlate with protection. None of those correlate with exposure when the test result is positive. Now, to expand on that, I would like to ask you, can you think of a positive test result that indicates the patient is only exposed and not protected nor infected? And this is important. You test for them, many of you, routinely. And certainly ehrlichiosis is a major example of a positive antibody result that only denotes the patient has been exposed. Likewise, anaplasmosis only means the patient has seen the organism and it does not confirm infection. That's the clinician's responsibility to do additional supportive testing. And another one that may surprise you is canine influenza virus. For veterinarians in the United States, and a few of you in perhaps Ontario have seen canine influenza virus. And it's important to understand that the viral phase of infection, the viremia, is literally no more than 2 to 3 weeks. And the antibody that you would detect usually is induced after the viremia has subsided. So a patient with prior exposure would have a positive antibody test, and they could be antigen negative. But it's also important to note that influenza virus antibody does not denote protection either. Even a well-vaccinated dog with antibody can still become infected and will transiently shed virus. It's a non-sterile form of immunity. And there's one other infection that I think you should be aware of. At least veterinarians in the United States must be aware of the fact that a positive antibody test only means exposure for one other important virus, and that's rabies. In the United States, a rabies antibody titer done at Kansas State University is only indicative of adequate vaccination. In law, a positive rabies antibody titer is not an index of protective immunity. It is very important every veterinarian practicing in the US understand that. All right, I'd like to move from the kind of this background information into the application of antibody testing. I'd like to talk to you about the role of antibody testing. What are the indications that you would actually consider when performing antibody tests? And I wanted to highlight one important point. In the latest iteration of the AAHA canine vaccination guidelines, we have an online menu-driven series of menu-driven options. One of the newest options we have added is a discussion on antibody testing for vaccine-preventable diseases. We have actually identified 12, there are probably more, but we have identified 12 rational reasons for which a practitioner might perform or conduct antibody testing on the individual patient. And this is for the dog. I think I would refer you to this for additional insight over and above this webinar. But it is insightful that this has been reviewed internationally and actually got quite good remarks from reviewers. Nothing like this out there anywhere else but on the AAHA Canine Vaccination Guidelines website, which is available to everyone. Let me give you one good example of where an indication in which you might want to select antibody testing in practice. Now, this slide that's on the screen now is simply the representative slide based on the recommendations for vaccinating the young dog. This is the initial series. And I think virtually all of you are doing something very close to this, recommending 3 initial doses for distemper, parvo, and adenovirus, generally around 2 months, 3 months, and 4 months of age, with some wiggle room built into that for clients who don't comply. And then, of course, a booster 1 year later. Now, if you look at this in another way, I wanted to incorporate maternal antibody into this slide. You see the 8 weeks, 12 weeks, and 16 weeks across the bottom. The purple curve that's denoted here represents maternal antibody. Maternal antibody we don't specifically measure, but we assume it's there. Now, one point that's critical, maternally derived antibody is the #1 reason that vaccines fail to immunize. That's why we administer 3, or in some cases 4 doses of vaccine to the young animal, is to be there with 1 dose when maternal antibody is not there. Now, for years, we have given a dose at 8 weeks or so. If maternal antibody is present, maternal antibody will effectively neutralize the vaccine antigen, and there is no immunity. So we have administered vaccines at 3 months of age, 12 weeks, and if there is sufficient maternal antibody present, there is not going to be an immune response to those antigens. Hence, we've recommended several years ago that a 3rd dose was very important, and we have assumed for several years that 16 weeks, no concerns about maternal antibody interference, and the patient can reliably be considered immunized. And within about 7 days after that last dose at 16 weeks, the clinician and the client can be relatively confident the patient is immune. But new data, not yet published, out of the University of Wisconsin has done some serologic surveys across the United States. Thousands of dogs are involved. And what we have discovered through these studies is that as many as 15% of dogs in the United States vaccinated at 16 weeks of age are not immunized for distemper and parvovirus. This was quite a revelation. And it does raise concerns that maybe we're not immunizing the entire population at risk. The question then comes up, did this patient actually become immunized? Now, here's the scenario. You have a client who now owns a very valuable dog, a $4,000, some kind of a doodle, and they want to travel with that dog, and they do. They go to shows, they sell these dogs at dog shows. Their airplanes are filled with dogs today. It's remarkable when you see that. I think in the case of the individual client, this would be a very valuable, useful asset to be able to test that patient after the completion of the series, the initial series of vaccines. And what we are recommending today is that if the antibody test is done 2 to 4 weeks following the last dose to give antibody an opportunity to be induced, then that would give you insight into whether or not the patient is truly immunized. Now, if it is negative, interestingly, then the actionable item would be to immediately revaccinate that dog. So it would be a recommendation to give an 18 or 20-week dose of vaccine. That gives you the confidence, at least, of knowing that that patient, before it gets on an airplane or begins going to dog shows or daycares or whatever, has exposure to other dogs, is in fact immune. While this isn't for every client, it is, I think, an option for specific clients that may want that kind of information and who may own a particularly valuable dog or a group of dogs to have that kind of information before they begin the increased exposure risk. Interestingly, if that patient, when it's retested, is still negative, there's another issue at concern. This is not maternal antibody. I think many of you remember the Doberman parvo and Rottweiler parvovirus failure to immunize from the 1980s. This was a subset of dogs that failed to respond to the parvovirus vaccines at a time when parvovirus was raging throughout the world. So we find that this is not maternal antibody. In fact, it's a very, very select genetic flaw in that these dogs apparently fail to express the epitope on the antigen presenting cell that binds to the parvovirus antigen. They do fine with distemper. They do fine with adenovirus, just parvovirus. Now, we have noticed, and this is more recent, that there are concerns being expressed by veterinarians of families, groups of dogs or breeds that are not responding to parvovirus vaccine. One of the concerns that has been expressed to me, and this is from the East Coast to the West Coast of the United States, is an increase in parvovirus cases among well-vaccinated pit bull terriers. I've had one case in, I believe it was Massachusetts. A veterinarian called me and they had 4 pit bull pups, all vaccinated out to 19 weeks, all of which developed parvovirus between 6 and 9 months of age, all of them. And I think that knowledge that these dogs responded or didn't respond to vaccine may have at least helped make a difference. The fact is, if they do not make antibody, they are not protected. They are susceptible in that situation. So it's a piece of information that I think is particularly useful in the clinical setting. Vaccinate or test. Now let's move to the adult dog. Do I give it a booster dose just because it's time, or should I actually test? This is a question that is being driven largely by the client, not by the veterinarian. Now, if you look at this, I stole this from a website, titer before over-vaccinating. Whether or not you are aware, there is an abundance of anti-vaccination websites for pets. And this is one where that poor small dog is being attacked by about 15 or 20 syringe and needle to pulverize this poor thing, to make owners concerned, raise the concerns among owners about testing rather than just randomly administering vaccine. Now, what I've experienced is owners are concerned about things like pet over-vaccination, vaccine injury that largely stems from the purported autism, measles vaccine link, just unnecessary vaccination I've heard this many times. You veterinarians are just giving vaccines for the money, and we don't really need the vaccine. It's not a real disease, that kind of thing. What I'm saying here is that as a clinician, this gives you an option to do an antibody test. It's a valid, reliable testing platform that gives you and the client information that they may be seeking. Now, whether or not you support this, but the client may be driving this in some situations. Now, what this ultimately has driven is yet another question, and this is relevant too. If you do a test on a dog that's due for a booster, the owner would elect to test rather than just randomly vaccinate. That question that comes up is this: if the test is positive today, will it be protected tomorrow, or a year from now, or 3 years from now? In other words, does a positive test look forward? Now, I want to challenge your thinking on this. A positive antibody test today means the patient is, in fact, protected for distemper, parvovirus, and adenovirus. But it also tells you something else. It is a sentinel test, if you will, for memory. In other words, if they've made antibody, they must also have memory. And these are B cells sequestered in germinal centers of lymph nodes that are going to remember for many years, probably for life, for the antigens we're discussing. If they see it again, they will rapidly, literally within hours, begin to boost themselves because they have memory. So it is an option to say, yes, we can test today. And if they are positive, we know they are protected. But we also know that in the adult dog, they have developed memory, and they will be protected for several years from this point forward. And this one we've all experienced, dogs or cats that have had a history of an adverse reaction to a vaccine. This is classic angioedema. It occurs within about 3 to 6 hours after a vaccine, typically, and it can be quite alarming. Rarely, if ever, causes serious injury or death, but it is a rather obnoxious side effect to the excipient proteins in the vaccine. Interestingly, this is probably not the vaccine antigen that promotes this. It's the other proteins in the product. Now, the question is, I can manage this patient today, but what do I do when the patient comes back? Is there a risk associated with a more severe reaction if I administer another dose of vaccine? Have I hypersensitized this guy to the point that he's going to have anaphylaxis? And I think it is relevant to say, okay, let's do a test. If you test this patient, you would know immediately within 25 minutes whether or not the dog has made antibody. If the test is positive, it is reasonable to delay any boosters that might be indicated. We know in children that have this type of reaction, and it does occur in children as well, that as they age, the risk of angioedema of the face does diminish over time. We don't know that in the dog, but it's probably true. But the bottom line is it does give you assurance that the dog had responded to the vaccine, and revaccination could be legitimately delayed. The downside is if the patient is negative for antibody, it becomes your decision whether or not to administer the vaccine, in which case it may be helpful to give an intradermal dose, 1/10 of an ml, for to look cutaneously for an arthus reaction or a wheal to see if the dog is in fact reacting to any of the proteins in that vaccine. If they are, it would also be an indication to further delay vaccination. And one option. Now, just very quickly, I'm going to close our webinar with just a brief introduction to some of the other indications that we have found veterinarians are using antibody testing for. And one of the age-old questions that I get in vaccine seminars is, what age do we stop vaccination? I can tell you that most practitioners, at least in North America, tend to recommend discontinuing vaccines around 10 years of age for the dog and 10 or 12 for the cat, with the exception of rabies. Rabies, no opportunity there. You should continue vaccinating throughout life at the appropriate interval. But here is a means of assessing a reason to discontinue vaccines. If an 8 or 9-year-old dog has a positive antibody test to distemper, parvo, and adenovirus, vaccination really isn't on the table. They're immune, they're protected, and they have memory. If they have a negative test, it is indicated and recommended, even though they probably have memory, to revaccinate them. Now here's one. All of you know that every vaccine licensed on the market today says for administration to healthy animals. Well, what do you do about a 6-year-old cushingoid patient? Any dog with a long-standing systemic or chronic illness is a challenge when it comes to vaccination. Could you just vaccinate the dog? Yes, you could. And in some cases, states require rabies, regardless of the health status of the dog. But for distemper, parvo, and adenovirus, you at least have the option of testing to determine whether or not they even need a vaccine. If they are positive, I would certainly advise delaying administration of a vaccine. If they are negative, then it's your call. You've got to come to grips with the purported risk of that individual patient, risk for exposure, versus the risk of giving a vaccine, which in the case of a serious chronic illness like Cushing's disease, the patient might not respond to the vaccine. I don't think the vaccine is posing a risk. It's just failure of that vaccine to induce a protective immune response or a boosting effect when the patient has a serious systemic or chronic illness. Dogs with a history of immune-mediated hemolytic anemia or thrombocytopenia. The interesting issue is, do vaccines cause immune-mediated disease? We don't really have hard science behind that question. But a lot of the immunology experts that I get to sit at the table with suggest that vaccines may not actually cause immune-mediated disease, but vaccination could, in fact, reactivate it in a patient with a history of immune-mediated hemolytic anemia or thrombocytopenia. So the point is, in the AAHA canine vaccination guidelines, we have recommended against arbitrarily administering vaccine to any patient with a history of an immune-mediated disease. So this now, the opportunity gives to actually test the patient, gives you objective information as to whether or not the patient even needs to be vaccinated. And one other indication for any of you who are attending this webinar who might be consulting with or working with an animal shelter. In the AAHA guidelines, we consulted with many of the shelter veterinarians across the US and outside of the US regarding the role of antibody testing in the existing patient population faced with the risk of an outbreak. Now, the turnover in an animal shelter is such that you never know what's coming in on the truck that day. If a dog is exposed or infected with distemper or parvovirus, there is a population at risk within the shelter. And the worst thing to do is be continuously introducing more and more virus. Well, the opportunity to, once a dog obtained or an entry to a shelter is identified as sick and infected, it is possible to then test individual dogs within the shelter in order to determine which ones are protected, which ones are not at risk. And for those that are in fact at risk, particularly the young ones, they can be fostered or moved or isolated to minimize the risk of transmitting this disease throughout the entire shelter. And worse, and you've all heard this, oh my gosh, we've got parvovirus in the shelter, and the decision is made by the management of the shelter to euthanize all the dogs. This happens every year. And this is a management tool that in the shelter setting could actually be quite valuable. Well, let me stop at that point. I wanted to again simply reiterate this is an important patient-centered management resource for clinicians. It does require knowledge of what the test means and mandates your interpretation of the test results for the specific indication that you're testing for. I hope this has helped, and I hope it will provide you with some insights on the role of antibody testing in practice. And at this point, Albert, I think we can go ahead and take any questions that might arise.
Absolutely. Dr. Ford, you have done a great job once again with the presentation. The feedback from the global audience has been nothing short of phenomenal. There are a lot of questions that have been generated, and we wanted to assure all of the audience members that if Dr. Ford is unable to answer all of these questions during the allocated question and answer session, he will be following up with you after this webinar. So thank you for the great questions. Please keep them coming in. Dr. Ford, one of the very first questions that came in from Palm Desert, California. Dr. Pappas is asking, is there a way to hypothesize how long the immunity detected with the in-house test kit will persist?
Yeah, and that's really a very fundamental question to all of this. I'm glad this has been raised again. The actual duration of immunity of vaccines will vary for distemper, parvo, and adenovirus. Most of the studies have been done at the University of Wisconsin. When you correlate a positive antibody test result, whether quantitative or qualitative, once they are positive, they have memory. To our knowledge today, distemper is at least 9 years. Parvovirus is very likely for life, dog and cat. Adenovirus is probably at least 8 or 9 years. So nobody has really done the definitive lifelong studies. And the other thing that Dr. Pappas's question raises is there are always some dogs that are not as robust responders, and they may not have sustained levels of protective antibody, although they may have memory. We don't measure that. So testing in that scenario, and many veterinarians will test every 3 or 5 years. If they are negative, it is conventional to give a booster and raise the titer again. Good question.
It was great. We have a question this time from across the ocean in Lisbon, Portugal. Dr. Amaral is asking, is antibody titer directly correlated to effective immune function
No. Dr. Amarillo has asked a very good question. I actually wanted to raise that during the presentation, but it is important to note that the amplitude of the titer is not a correlate of the degree of protection or protective immunity. You're either positive and protected or you're not. And so the amplitude is simply a dilutional measure of the concentration of antibody. The degree of that amplitude is not, interestingly, a correlate of the degree of protection.
Excellent. Thank you for that. And now, Dr. Ford from Turkey, Dr. Oguz Kul is asking you, what is the best vaccination strategy for dog shelters that are having an active current outbreak of canine distemper, as well as canine parvovirus? And does VacciCheck work on differentiation of infected puppies?
Well, VacciCheck is not a test used to diagnose the disease. I think even in Turkey, throughout the world, there are fecal antigen test kits that would do a much better job of identifying the early infected patient. The question that's being asked, and I've just been at a shelter medicine conference where we address this, is a very challenging issue. What do you do in the face of an outbreak? I think one of the largest challenges is the vaccines do not work immediately. Therefore, once parvovirus and distemper virus are inside the facility, it's extremely difficult to eliminate the risk of exposure without reducing or depopulating the infected group and identifying, this is where VacciCheck would be useful, identifying patients or dogs that are antibody positive and therefore protected. In other words, separate the susceptible from the protected. It's a large and challenging issue. I've always said that shelters do not do infectious disease prevention. They can really only do infectious disease management because the exposure risk is so high. Very complicated question, but understand the limitations of the VacciCheck test, not a diagnostic test, but it would identify reliably the protected patient population.
Great, thank you. And from Chicago, Illinois, we have a question. Do you have any suggestions on how to educate pet owners on the importance of vaccine titer testing? Some of them, I fear, may ask me why I am now offering this service. How do I answer that question?
Yeah, that's a really good question. We haven't really addressed that specifically, but it is a relevant point to this discussion. How do you introduce that to the client? For me personally, and based on my experience as I go around the country talking to veterinarians about vaccination and protocols and testing, is that it represents an option. Here, this is one of the great things veterinary medicine brings to the table, is we can provide options. We could just give the vaccine. If you are anxious about that vaccine, or you are worried that something might happen, or you're concerned, let's do the test. In 21 minutes, I can have an answer for you, and we can make an educated decision at that point. If you're okay with just doing the vaccine, we'll do our best with that, and likely it'll work well. Those are really, Albert, I think for this question, I think the emphasis is it is another option on the table for the client. It's not a you will do this or you will do that. It's just something else that's possible.
Great response, Dr. Ford. And now back to Turkey. You are generating all kinds of questions, Dr. Ford. Dr. Duygu Karaman is asking if they have an 8-week-old puppy, can we do this test to see or identify maternal antibodies before vaccination? And what Dr. Karaman means is if the dog is negative for all these diseases into the 8th week, say there are no maternal antibodies in the dog's blood, and would one dosage of vaccine be enough for this particular dog, or would we still need a second and third dose?
Yep. Albert, this is a very good question, very insightful question to ask, relevant to this discussion today. And I'm going to make a point. You should not do a VacciCheck test or any of these qualitative, semi-quantitative tests in an animal younger than about 18 weeks of age. And the reason is that it might, although we don't know at which level, it might detect maternal antibody. Now, it could interfere or confuse the issue in making decisions on an individual patient. So we have all recommended, no, don't use it in the very young 8-week-old animal. Now, there's another point that the veterinarian is bringing up, and that is, can I rule out maternal antibody? And the answer is no. I would say, and some of the experts from VacciCheck could verify this, but they have established a threshold for positivity, and that threshold may be well above the amount of antibody needed to interfere with vaccine. So there's not a good correlation, or I wouldn't think there would be, between a negative test and, quote, no maternal antibody. In other words, you could get a negative test, vaccinate the dog, but the residual amount of maternal antibody, apparently it takes very little, could still interfere with the vaccine. To answer the question, I would follow the protocol out to 16 or even 18 weeks.
Great, thank you, Dr. Ford. Dr. Ford, we have had just a deluge of questions. We are actually running out of time, so this will be our last question, but I wanted to reassure all of our participants that we will be following up with answers to all of you who have posted questions that we could not get to. So Dr. Ford, the last question is from Jessica Case, and she is asking you, if there is a positive titer that is returned at 18 to 20 weeks of age after the initial vaccines, would a booster at 1 year still be recommended? Could you not just run a test 1 year later and use those results to determine if a vaccine is required or not?
You know, the questions are getting harder, Albert. That's a very interesting question. I don't have data. Nobody has actually looked at that. I think it's really interesting to address this as a question. My point is that when you give 3 doses of vaccine and the last dose is at 16 or 18 weeks, the patient is not fully immunologically mature. And it may develop a robust immune response at 16 weeks, it may not. But in all the years I've worked with the AAHA and AAFP guidelines, we would strongly recommend a booster after that 16 or 18 week dose, somewhere around a year later. At that age, the patient's immune system is fully mature. Both dogs and cats aren't mature until about 8 months of age. Then you would expect the full immune response. Now, to test them at 1 year and 4 months of age, in other words, a year later, if they are positive, it's probably an excellent indication that they have memory and they're good. they're good to go. So for the client who is concerned, yes, you could probably do that. I'm not sure in the long run or with large numbers of patients if that would be wise to do. It's a good question to ask and something that would be really interesting to look at in the future.
Great. Well, Dr. Ford, we are out of time, and I wanted to let you know that there are a number of participants, such as Lucy Eade, as well as the Natalie Cochran and Elia, who have just been praising your presentation. They said that they've learned so much from it. We have Dr. Granby as well. And for all of you, I promise that we're going to follow up with all of your questions. Dr. Ford, as always, it is a pleasure to be able to work with you on helping to advance continuing education with vaccine titers.
Thank you, Albert. Appreciate that.
All right. Take care and have a great day.